Hi, I'm Ann Eglash, a family physician and a board-certified breastfeeding medicine specialist in Madison, Wisconsin. I'm a clinical professor at the University of Wisconsin School of Medicine and Public Health, and I'm also the CEO of IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education.
Hi, I'm Dr. Lena Edelstein. I am certified by the North American Board of Breastfeeding and Lactation Medicine, a board certified pediatrician, and international board certified lactation consultant. I care for breastfeeding diets in private practice in the outpatient setting.
Hey Lena,
Hi,
how are
Ann.
you?
I'm doing well. How are you today?
Good, good. Let's talk about breastfeeding.
Yes. Well, I'm going to talk today about a study that raises some important questions about the increasingly common use of donor human milk in healthy term and near-term newborns. Donor milk is increasingly being available in well baby level one nurseries, including for healthy term and late preterm newborns who require some supplementation, which seems like a great option, right? Like if a breastfeeding parent needs to supplement for medically indicated reasons and their own colostrum, their own milk is insufficient, donor milk gives us an alternative to formula and getting all these immune benefits into these newborns.
And you're
And
talking about, just to be clear, you're talking about the pasteurized banked human milk. You're not talking about people like bringing in donor milk from other people, right?
correct,
Yeah.
I'm talking about pasteurized donor human milk like via milk banks.
Okay, good.
Yep. So today's paper looks at how donor milk is being used. And is it being used in a way that actually supports breastfeeding and lactation?
Hmm.
The study is titled Donor Human Milk Utilization in a Level 1 Newborn Unit of a High Volume Delivery Hospital, a Cautionary Tale, which is a little bit of an ominous
Yeah.
title, but we'll go through this more. And the authors of this study are Lindsay Daggle and her colleagues. So, what did they do in this study? The researchers looked retrospectively at all newborns discharged from a large high volume hospital during the year 2022. So from January 1st to December 31st of that year. This hospital has more than 10,000 deliveries a year, and its level one nursery cares for newborns 35 weeks gestation and older. Of more than 10,000 newborn discharges, about 9,000 newborns were eligible for this study after they excluded babies who spent time in the NICU or in some other acute care units. And of those 9,704 newborns who eventually ended up included in the study, 1,094, or about 12%, received donor human milk. So that's about one out of every eight newborns in this level one nursery. That's a
Yeah,
very large number.
doesn't surprise me though, because if you look at like national levels of supplementation during hospitalization, it gets pretty high. It's like from 17 to like 30% or more. So yeah.
Yep. So, who is receiving donor milk? The newborns who received donor human milk were more likely to have characteristics that made supplementation more likely in the first place.
Mhm.
So, for example, the baby recipients were more likely to be born between 35 and under 37 weeks, born by cesarean delivery, or diagnosed with hypoglycemia. And notably, no significant differences were noted between formula and parents' own milk for these newborn characteristics.
Uh, you say that again? I'm not sure I understand that.
So they were comparing in this study newborns who received any donor human milk, newborns who received any formula, or newborns who were exclusively fed their parents' own milk.
Hmm. And what was it? What did they find regarding that? That there
So
were,
there were no significant differences were noted between formula usage and the parents' own milk for these newborn characteristics. But with these characteristics, the babies were more likely to receive donor human milk.
I see. Okay.
We'll talk a little bit more about that soon. Another characteristic of babies who are more likely to receive donor human milk were that they were diagnosed as small for gestational age. But for this characteristic, there was no differences in the proportion of infants who were small for gestational age newborns between the donor human milk and the formula groups.
Mhm.
So this makes clinical sense because these were specifically indications in the hospital's donor human milk protocol as reasons to supplement a baby. The study also noted that newborns receiving donor human milk had longer hospital stays. So the median length of stay was about 65 hours for donor human milk recipients versus 47 hours for newborns who did not receive donor human milk. However, this was an association, not causation. So there wasn't evidence that donor milk caused the longer hospitalization. Just these infants had more medical and feeding risk factors to begin with.
Hmm.
The study also noted some sociodemographic factors and different characteristics between those who received donor human milk and those who did not. But I'm going to talk about that in a little bit.
Yeah, I was going to say that's probably that there's a lot of data on that too. So I'll
Yes,
look forward to hearing what they found.
definitely. So, particularly interesting was the variability in the volume of donor milk newborns received, which was really substantial variability. Across the year, the hospital used more than 6,500 ounces of donor milk. And among the newborns who received donor human milk, the median total amount was about 3.9 ounces or 118 milliliters. Um, the most frequent amount of donor human milk doses that they received was 6. But the individual volumes ranged anywhere between 2 to 50 milliliters. So some
Mhm.
of these volumes are in the supplemental range, and others are pretty much a full feeding for a newborn, 50 milliliters,
Yeah, for an older newborn, like day 3, day 4. Yeah.
right?
Yeah.
So this hospital's protocol did not specify maximum total volumes to use, maximum volumes per feed, the duration of donor human milk use, or any clear criteria for discontinuation. So, in practice, once donor milk was started, newborns were sometimes receiving anywhere between 15 to 30 milliliter bottles of donor human milk every 3 hours until discharge. And there wasn't necessarily a trigger for reassessing whether supplementation was still needed. So, why might excessive supplementation matter? One concern raised by the authors is that donor human milk supplementation can inadvertently interfere with the establishment of lactation. So, in the first few days after birth, milk production is highly dependent on effective and frequent milk removal. And if a newborn receives a relatively large volume of donor milk, like in that order of close to 50 mLs, they may be breastfeeding less frequently or transfer less milk at the breast. And if the lactating parent isn't making up for that, isn't compensating with additional milk removal, whether it's by hand expression or the use of a pump, they may be in there may be that inadequate breast stimulation and milk removal to really establish good lactation. Um, this could create a potential cycle leading to continued need for supplementation. This study, it's a retrospective study. It cannot prove that this happened. And in fact, one of its major limitations was that the investigators didn't have reliable data on direct breastfeeding frequency or subsequent breastfeeding outcomes after hospital discharge. But the concern is clinically plausible, and it's important enough that should influence how hospitals design their donor human milk supplementation protocols and any supplementation protocols.
Yeah, I think, yeah, I just would interject that, it's like anything else that's supplemented, right? I mean, the effect of supplementing with donor milk is not going to be much different than the effect of supplementing with formula, other than maybe people feeling better about that supplementation and feeling more hopeful that if breastfeeding gets going, their baby still is exclusively breastfeeding. But beyond that, we have evidence that supplementing, even with mother's own milk, in the first week is associated with a decreased breastfeeding incidence at 6 months. So any kind of supplementation is associated with with premature weaning.
Right. And I think um, maybe this goes back to the title, a cautionary tale, using donor human milk. It has human milk in the title, but remembering that it is supplementation still, and the everything that you were saying, and still applies.
Yeah. And yeah, I was just going to say too that education for healthcare staff, we're so siloed, right, in terms of like our support for breastfeeding. So you have these healthcare staff who are doing what they feel is the best thing for these babies, right? They're not getting formula. We're protecting their gut microbiome. We're giving them donor milk. We're preventing them from having excessive weight loss, preventing them from getting readmitted. But they also have their blinders on in terms of like what this means down the road, and also understanding how to support lactation. So it's not just like, oh, you're getting human milk, oh, your baby's latched. It's really protecting the ability for that mother or for that lactating parent to really to establish and maintain lactation by just sending that really strong message to the breast, and keeping that person, helping that person maintain frequent and strong milk removal.
Exactly. So another important finding I wanted to talk about was the inequities that they detected in who was utilizing available donor human milk.
Yeah.
So one of the most concerning findings was the difference in donor human milk utilization across different sociodemographic groups. Newborns were more likely to receive donor milk when their birth parents preferred English as their language, they
Hmm.
identified as white or non Hispanic,
Hmm.
or they had a non Medicaid insurance. And this occurred even though the hospital absorbed the cost of the donor milk during the hospitalization, and they didn't restrict access based on insurance or ability to pay. So, what could explain this disparity? The authors raised several possibilities, and one of them was the consent process.
Hmm.
So, parents had to provide their assent for using donor human milk. And for families who did not speak English, that required an interpreter and additional time from nursing staff.
Hmm.
Formula, by comparison, was able to be provided without these additional steps. There may have also been cultural differences in acceptance of donor milk, language barriers, implicit bias, or concerns about the cost of obtaining donor milk after discharge. So we can't use it in the future. What's the point of starting it now? Notably, these are all hypotheses. They were not conclusions proven by the study, but they do give us an important clinical lesson. When a resource is available, it doesn't necessarily mean that it's equally accessible to everybody just because it's available at the institution.
Right, right.
So again, when developing these hospital protocols, it would be really important for those who are developing it to look at the pathways by which families are offered supplementation and to see whether that pathway really works equally well for all patients.
Right. Yeah. Yeah, no, yeah, I think there's got to be some judgment by staff, like, oh, this person's going to formula feed anyway, so why would we supplement with donor milk? Whereas when we look at some of the research, it does seem that just receiving cow's milk-based formula in those first 3 days definitely has an effect on the risk of cow's milk allergy later, even if they go on to be formula fed. So we need a lot more research just looking at what is safe in those first 3 days. So judging it based on whether or not they're going to formula feed or not may not be in the best interest. And then, of course, there's other factors like, oh, they'll never be able to afford it. Oh, they're not going to breastfeed. I think that there's some strong research about the inequity of access to donor milk, and it would be nice to do some qualitative research to understand that more, like what goes on in those conversations or lack of conversation. Uh,
Hmm.
so yeah, this is definitely good information, and we just need to really expand this research on the use of donor milk. Yeah, in the newborn
Yes.
industry. Yeah, right.
Yeah. So just wanted to go through just a few big takeaways also for clinical practice.
Hmm.
Um, so like you were saying, so donor milk alone, it's not an entire strategy in and of itself, but it should be part of a breastfeeding supportive supplementation strategy. Um, when developing protocols, having clear criteria for starting supplementation, but also stopping. So, constant conversation about why are we starting supplementation, and then contingency planning, follow planning. What needs to happen for supplementation to stop,
Yeah.
and a constant reassessment for that. Standardizing supplementation volumes and having that be included in protocols, and
Hmm.
then looking for and then addressing inequities and structural barriers beyond just having donor milk be available.
Yeah. Yeah.
So it's a donor milk is an important tool and should continue to be used thoughtfully. And many thanks to these authors for having the ability to really see how it is being used within their institution.
Yeah. Yeah. That was great. Yeah. Well, thanks for sharing that. And it's food for thought. Haha. And we need to keep talking about this. So now we're going to sort of switch to a whole new topic, which is about fractures and breastfeeding. So this is an article that was entitled Parity, Age at First Birth, Breastfeeding, and the Risk of Major Osteoporotic Fractures in Middle-Aged Women, and it's called the Hunt Study. And this was done in Norway. The first author is Gharehkhani, and this was accepted in July of 2026, so in the Osteoporosis International Journal. So women of childbearing age who are, going about having kids, busy breastfeeding, they're not necessarily thinking about their future bone density because it's so far off. But in reality, reproductive status has been thought to have a significant impact on future bone density. And this is an important topic because low bone density and osteoporosis are really common. 1 in every 3 women over the age of 50 will experience an osteoporotic fracture. And as women get older, like in their 80s, there's a 25% risk of death associated with a major osteoporotic fracture, like a hip fracture.
Wow.
Yeah, so it's pretty serious. It's a major health, public health issue, right? Over the last several decades, we've seen a lot of conflicting research in this area about whether the bone loss that's experienced during pregnancy and lactation leads to stronger bones later due to remodeling, which would be exciting, versus the bone loss not impacting future bone health versus it actually being a risk factor for osteoporosis in advanced years. So we don't really have the full picture, and there's probably a lot of confounding factors. But this was a pretty strong study. This was a huge study that was done in Norway, where they have a very high incidence of hip fracture. So there's a 23% lifetime risk of hip fracture among women. So they wanted to see in this study what are the reproductive factors that are associated with that higher risk of hip fracture. So this is a retrospective population-based cohort study that was based on some data from the Tronstad health study, which linked records from the birth registry in Norway and hospital-based data on major osteoporotic fractures. So they have this whole lifespan of data, which is one of the major benefits of a national healthcare system, which, we unfortunately will not be able to experience here. So the researchers invited Norwegian residents to participate via survey, and about 50 to 75% of invited women participated in each cohort. So they had a different cohort for every decade, like the 1980s, 1990s, 2000s. And they went from 1984 to 2019. So they actually had a pretty good pickup of women who were invited to the study. And the survey asked about the number of births, the age at first birth, and then the lifetime breastfeeding duration, meaning the total number of months that they breastfed between all their children. And then they checked their medical records on major osteoporotic fractures, which could have been a hip, a distal forearm, a proximal humerus, or the spine. So this was a pretty large study. They had 41,274 women with an average mean follow-up of about 12.3 years. Women had to be 45 or older to enroll in the study, and the
Mhm.
average age of enrollment was 52. And then during this time, this whole like cohort time, they identified 7,520 osteoporotic fractures. So results, as one would expect, the higher number of births, the longer lifetime duration of breastfeeding, but they were able to tease parity and breastfeeding apart. So in terms of parity, the more babies a woman had, the lower her risk of major osteoporotic fracture. So they calculated that every additional birth was associated with a 2% lower risk of fracture, which is
Wait,
interesting.
so more pregnancies,
Yeah, the
less
lower risk.
fracture.
Yes, yes. And that's going to tie into this other issue, which is that the incidence rate of major fracture decreased with advancing age at the first birth. So women who had their first birth at over 30 years of age had an 8% decreased risk of fracture. And they calculated that every 5-year increase in age at first birth was associated with a 3% reduction in fracture risk. So the reason they think that happens is that women don't really reach their peak bone accrual until they're 25. So if they're having babies under 25 and then losing that bone density during pregnancy and lactation, they never reach their peak bone density accrual at age 25.
That
Um,
makes sense. And
yeah,
then also, I guess also if they then after delivery, if they were breastfeeding and they were not ovulating, then
right.
maybe then there would be less opportunity to rebuild their bones while they were breastfeeding when they're in that still that younger age of when they could be reaching their peak bone density.
Maybe, but
Maybe. Okay,
we're
maybe.
gonna come to that in a moment. So the risk of major osteoporotic fracture decreased with the duration of breastfeeding. So those with the longest duration of breastfeeding had the lowest risk of osteoporotic fracture. They calculated that every additional 6 months of lifetime breastfeeding was associated with a 1% reduced fracture risk. So if a woman breastfed for more than 21 months, they had an 11% decreased risk of a major osteoporotic fracture. And so and we'll talk about this
So
because I
surprising
both,
to me. I mean, I love hearing it, but
yeah,
I am pleasantly surprised.
right, exactly, yeah. So I should note that when they adjusted for a lot of other factors like how old the woman was, menopause status, hormone replacement therapy, alcohol consumption, body mass index, smoking, and physical activity, they still saw these same findings with this relationship between osteoporotic fractures and parity and breastfeeding. So there were a few other interesting findings. One is that the effective parity was mainly protective for hip fractures, but not for spine fractures, whereas breastfeeding duration protected from both hip and spine fractures. Yay for breastfeeding. Also, the other thing that I thought was fascinating is that exclusive breastfeeding for the first 6 months had a stronger protective association than the total lifetime duration of breastfeeding, which I thought that's so interesting. And
Oh,
and the way I interpret that is that when women exclusively breastfeed, they will reach their nadir of bone density at around 6 months because after 6 months they're starting solids, they're not nursing with as much intensity, they're not losing as much calcium through their breast milk. and they're oftentimes starting to ovulate like, by 9 months. And once women start to ovulate, they start to reaccrue that bone loss. So if their bone density was lower at 6 months compared to women who didn't exclusively breastfeed, that makes me think that the remodeling that happens after that major bone loss plays a role in protection from osteoporosis later. And I've heard this theory before that like the body is like so good at like putting back like these amazing matrix, which is maybe a better matrix than what they had at the beginning. Kind of like I'm updating my house and now like the drawers work better and everything's like so much better in my house, right? Than the original way that we built our house. And so I wonder if that's what's happening. So and that's why I don't think like what you had said that the fact that they're younger, they lose their bone density earlier, right, during pregnancy if they give birth under 25. But then if they breastfeed if they exclusively breastfeed, they actually take an additional hit. I wonder if they're better off by breastfeeding longer because they will remodel better. And what's interesting is that younger women, if you look, demographically, they're less likely to exclusively breastfeed, right, than women who are older, at least in the United States in our stats. So it would seem to me that for women who have babies younger, it's really even more important for them to exclusively breastfeed, even though you think, oh, yikes, they're going to lose more bone density, but then they're strong and they can really rebuild that matrix well. I think this is great work. This really is supported by lots of other research. I would say the one thing, though, is that they didn't look at vitamin D levels. And this is a population, they have a high rate of fracture, hip fracture, and they're way far north near the Arctic Circle, right? And
Yeah.
so they're not getting as much vitamin D from the sun. So vitamin D levels would be really important. And we know from studies that having a low vitamin D level during pregnancy and during lactation adds to that bone density loss. So the authors also stated in their like future recommendations that this kind of work include calcium intake and vitamin D levels as well to see how much fractures can be mitigated by the addition, making sure that people are vitamin D replete during pregnancy and lactation.
Exciting stuff. And I love that my assumption was not what they found. It shows that there's so much more to really learn and understand, and more ways that breastfeeding improves women's health and is a
Yeah.
form of preventative medicine.
Yeah, I mean, when you think about it, I mean, we talk a lot about how breastfeeding sort of we will reverse those negative cardiovascular hits that people take during pregnancy, which we've talked about before. But then also bone density hit, like that's got to be fixed too, because we can't just like if our bone density never repaired after having several kids, we would just sort of like dissolve back into the earth by the time we're 55, right? Because you lose all that bone density. So there's got to be a way to like fix it, fix it, fix it. And I think it's cool to see how it would be really cool to see with the remodeling, if that remodeling process is better for women who are replete with vitamin D, who have good like weight-bearing exercise, good calcium intake, if they're more likely to have stronger bone density versus those who, have kids and are exclusively breastfeeding, but then don't have those additional tools to help those additional nutrients to make sure that they're really remodeling well.
Well, thank you for sharing that article, Anne.
Yeah, yeah, it's cool. All right, well, I think that's a wrap. So we will touch base again next month for
See you
more.
next month.
Yeah, bye.
Bye.
Thanks for listening. If you have questions or comments regarding this podcast, please contact us at admin@lacted.org. That's LACTED.org. You can also post comments or questions on our Breastfeeding Medicine Facebook page, and we will have links to our articles on the page. We have boatloads of breastfeeding education opportunities at our website, lacted.org. So come check us out and become a member to join our community.